Hi, my name's Ted O'Connell, one of the authors of USMLE Step 3 Secrets. This is the first of the 96 CCS cases in this book. Before we get started, we'd like to encourage you to visit medicalschoolvideos.com for additional videos and visit and like us on Facebook. So the history of the present illness. A 71-year-old male presents to the emergency department with 10 out of 10 intensity periumbilical abdominal pain. 1 hour prior to arrival, he was walking to the kitchen when he had sudden onset of abdominal pain radiating to the back. He felt dizzy at that time and had to lie down. The pain has been constant since then. Vital signs. Temperature is 37.1 degrees Celsius. Pulse 110. Blood pressure 100/75. Respiratory rate 20. Additional history. The patient is a 25-pack-year smoker. He has hypertension and is on hydrochlorothiazide. He has hyperlipidemia and is on simvastatin. What is the differential diagnosis? The differential diagnosis includes abdominal aortic aneurysm, acute coronary syndrome, pancreatitis, and small bowel obstruction. What components of the physical exam do you perform? The exam components that should be performed are general appearance, HEENT, cardiovascular, lungs, abdomen, extremities, and rectal examination. The physical exam findings. General, he is diaphoretic. There is visible discomfort from pain. HEENT is within normal limits. Cardiovascular reveals tachycardia. Lungs within normal limits. Abdomen, there's a palpable pulsatile abdominal mass. Extremities are within normal limits, and rectal examination within normal limits. What are your initial orders? Initial orders should include pulse oximetry, blood pressure and cardiac monitoring, CBC, a Chem8, LFTs, lipase, coagulation panel, urinalysis, troponin, electrocardiogram, a type and cross, chest x-ray, and abdominal ultrasound. Advance the clock. Findings of the studies include the ultrasound, which reveals a 7-centimeter abdominal aortic aneurysm. All of the other studies are within normal limits. What are your follow-up actions? Follow-up actions should include surgical consultation, surgical repair of the abdominal aortic aneurysm, admit the patient to the ICU with vital signs every 2 hours, CBC every 4 hours, and a chemistry 8 in the AM. Counseling should include counseling on activity, diet, and smoking cessation. Advance the clock, and the case ends. What are the critical actions in this case? Critical actions include abdominal examination, surgical consultation, and surgical repair of the abdominal aortic aneurysm. Now for a discussion of the case. This patient has a ruptured abdominal aortic aneurysm. The chief complaint in physical exam should prompt you to stabilize the patient and order a rapid imaging modality such as ultrasound or CT to assess for an aneurysm. Intravenous fluids and blood products can be used to treat hypotension, although there is evidence that the blood pressure should be kept relatively low as long as the patient is stable in order to prevent further bleeding. Immediate surgical consultation and repair should be obtained. The patient should be admitted to the ICU after surgery. A number of other routine tests can and should be ordered, but you should not wait for their results to proceed with emergent surgical management. An abdominal aortic aneurysm is defined as an abdominal aortic diameter of over 3 centimeters. Surgical or endovascular repair is generally indicated for any symptomatic aneurysm, aneurysm larger than 5 centimeters, or rapidly enlarging aneurysm. Smaller AAAs can be monitored with serial ultrasounds or CT scans. One-time screening is recommended for men 65 to 75 years old who have ever smoked. Most AAAs are caused by atherosclerosis, but some are caused by connective tissue disorders such as Marfan syndrome or Ehlers-Danlos syndrome. The most common modifiable risk factors are cigarette smoking and hypertension. Mortality of a ruptured AAA is very high and should always be considered in any older patient with abdominal pain, back pain, hypotension, or syncope. A ruptured AAA can be mistaken for renal colic in the elderly, but a new onset kidney stone in the elderly without a prior history is uncommon. Ruptured AAA can even present with hematuria. That's the end of this case. Please join us for our other videos on CCS cases for USMLE Step 3 secrets.